All right. Welcome everybody to our seminar series, the MIDAS seminar series on COVID-19. Today, we are delighted to have with us Karandeep Singh, who actually got his early medical training at our Michigan Medical School. And then he went off to various places, including Harvard and UCLA, and is now back as assistant professor of learning health sciences, of internal medicine, of urology, and of information. So Karandeep Singh, I think, exemplifies the kind of interdisciplinary work that we try to do and usually try to do by having partnerships and teams of people with complementary skills. And here we have a person who's a practicing informatician and also a practicing physician. And so I'm really delighted to have him speak to his experience with EPIC's deterioration index model for COVID-19 patients. Karandeep?
Jack, thanks for the introduction. Thanks for folks who are able to join and spend some time to talk about this topic. Today, what I'll be doing is I'll be talking about some of the, it'll be kind of told as a story. And so I'm going to tell you the story of kind of the various COVID analytics work that's been happening at Michigan Medicine kind of more broadly. I'll talk about what the motivation was for trying to validate the EPIC Deterioration Index model for COVID-19 patients at Michigan Medicine. This is obviously a model that we didn't develop, but we have running. And so, was something that we did out of necessity to try to figure out how we could use this to make better decisions for our patients. And then I'll be walking you through some of the kind of results and what we found. And so if you have questions along the way, feel free to type them into the Q&A. I'll try to check on those. If not, James will help me field some of any questions. And I'll definitely leave some time at the end for questions as well. So with that, let me go ahead and move on. So I'll say this in the beginning and I'll say it at the very end. But basically, our findings are non-peer reviewed. They're available as a preprint. You can feel free to take a look at our paper on this, and the code is also available on GitHub. And so any of the figures I'll be showing you or any of the main findings, you can kind of easily go and see kind of what was the code that we used to get to that on GitHub. In terms of disclosures, I do receive some funding from Blue Cross Blue Shield of Michigan for work that I do with the Michigan Urological Surgery Improvement Collaborative, or MUSIC. That's unrelated to this work, but it's something that I typically mention just for awareness. And then several of my collaborators on this received kind of federal funding and funding from MIDAS. And so I've listed that here as well. So the story begins really in kind of mid-March. And on March 16th, kind of shortly after the first patient with COVID-19 was admitted to Michigan Medicine, Michigan Medicine entered a planning phase to figure out how they were going to deal with this pandemic. You may have heard some of this in prior talks, kind of on different levels of scale. The level of scale I'll be talking about is really just at our institution, kind of laser focused on how the institution was set to try to address this crisis, in a variety of ways. So the very first thing that I think they did to try to prepare for this kind of influx of patients was activating this new unit in the hospital called the Regional Infectious Containment Unit, or RICU. This picture is Valerie Vaughn, who I believe is one of our hospitalists and was critical to try to figure out, what should be our treatment plan for these patients as they come in. helping us standardize protocols and care for these patients, so that we have kind of some standards that are being developed based on rapidly accumulating data and information and papers. But basically, this was 32 private rooms, and these rooms were kind of regular floor rooms, but were able to be converted into ICUs. And at their peak use, they actually were housing 2 patients per room and were all ICU level care. To give you an idea of kind of how it went from 32 beds to 64 beds pretty quickly. So that was the plan. And as patients started to come in, there was a lot of projections being made about what was going to happen at the state level, at the national level, and this was based on other international data. In some cases, it was based on what other health systems had observed with respect to kind of growth and census. And so that red arrow points to when this graph was released by Michigan Medicine, kind of as a press release. But basically, sitting on March 31st, the situation looked pretty dire. There's kind of 2 curves here, one curve assuming aggressive social distancing, one curve here showing what would happen if we didn't have aggressive social distancing. I think this was shortly before schools were canceled, and certain other changes were made at the state level. So there was a lot of uncertainty about what was going to happen at the state level and how it was going to impact these numbers. But the concerning thing really is that the best case scenario at that point was thought to be that we might exceed our hospital's census by 3 times. So, Michigan Medicine has approximately 1,000 beds. And so this peak census on that yellow line of, 3,179 was pretty alarming. And obviously, that was something that we had to plan, that, had to be planned for. So the same day that image was released by Michigan Medicine, there was this other kind of news release that Michigan Medicine was considering turning one of the indoor tract facilities into a field hospital. And the idea is that patients who were stable at the main hospital and not likely to need ICU level care could go to this facility if it were to open until they were kind of in a good enough situation to be able to be discharged either home or to a nursing home. And as many of you know, there's been outbreaks in nursing homes. So there was a real concern that if our hospital, kind of just slowly filled up, we wouldn't have anywhere to send healthy patients to for those who couldn't go home, because there were, very strict criteria at nursing homes for taking patients back who had previously been ill with COVID-19. And so the idea was that this was going to open on either April 9th or 10th, kind of 9 or 10 days after when this news story / press release kind of broke. We weren't the only ones at Michigan Medicine kind of worried about this uptick in cases. A lot of other health systems, including St. Joe's, Ascension, Bronson Methodist, had requested kind of approval for additional beds. The way inpatient beds are approved is usually kind of a very lengthy process because of the regulatory concerns. But because of an executive order that Governor Whitmer had released on March 17th, they were able to approve beds a lot more quickly. And so when this story broke on April 7th, there was already 4,000 new beds that had been approved at the state level for the care of this patient population that was expected to be, more than what most health systems were going to be able to handle with their existing bed capabilities. So there's this really nice Wired article that if you haven't seen, I would encourage you to look at. This is not your usual article. This is a very long form prose article that walks through in detail what the discussions that happen at the leadership level at Michigan Medicine within the command center. And I'll highlight some of the key things that were happening when we were asked to do some of this work. But I think this quote by Carolyn Lyles below that picture was a really telling one. And it was that we hold ourselves to such a high standard of care. And when you face the possibility that there may be 3,000 patients that are going to overwhelm our health system, you know, it is very jarring as a clinician to face that possibility that you may not be able to deliver the, you know, same level of care or the same amount of care that you're kind of used to delivering, where you spend a lot of time with patients, you examine them, you do, you know, all this work to risk stratify who's sick, who's not. If you have the same number of clinicians and 3,000 patients, doing that is going to not work with kind of existing workflows. So we have to be able to use help when we can, to be able to triage on that level of scale. I mean, that's a kind of catastrophic disaster type scale where, you know, you have to triage. So that's kind of what we were preparing for. And there's this really, I think, telling quote from this story, that there was a conversation happening, and I think the Detroit hospitals had started to fill up, and there were transfer requests that were starting to be made for patients in Detroit to be able to come to Ann Arbor because they didn't have the bed capability at that time. And I think originally the organization was thinking about possibly, you know, not taking a lot of transfer requests, recognizing that we were going to fill up with our own patients. But there was a kind of a realization that, you know what, we're all in this together. We've got to take these patients. And so even those kind of, that chart I showed you with, you know, 3,000 capacity, and here's when we were going to max out, they kind of threw that out the window and said, we may max out a lot sooner. We don't know, but we'll just take whoever we can safely. And so throughout this, you know, a lot of patients have come from other places around the state, primarily Detroit area, to be cared for at Michigan Medicine with COVID-19. One of the things that's not mentioned in the story, though, that I wanted to draw attention to is that when the command center was set up, that was kind of a set of leadership folks who were meeting, you know, every day and managing and making kind of key operational decisions for how to care for these patients. There was also a consolidation of analytical efforts happening at the operational level. And so there was a formation of a new team called the COVID analytics team, which was essentially, you know, a bunch of different folks from across Michigan Medicine, primarily on the operations analytics side, brought together to try to rapidly develop dashboards that the institution needed to make key decisions. You can think of things like around supply chain, you know, needing to make sure we have enough masks, gowns, all the way to, you know, expected census, how many patients we thought we were going to have, and a variety of kind of related data points to make decisions. And one of the asks that came from the command center was, which patients should we send to a field hospital? You know, who can safely go to a field hospital? Is that something that we want all of our clinicians to determine? Or really, if we're actually as overwhelmed as we were concerned we were going to be with an influx of patients, we might need some help from, you know, other ways of risk stratifying patients. And so we were kind of charged with identifying, is there any risk stratification tool that we can reasonably use to make decisions or to help us make decisions about, you know, transferring patients out to a field hospital, and recognizing that we had kind of a 10 to 14 day turnaround period of time from when they asked that to us to when the field hospital was set to open. We, you know, determined there was just not going to be enough time to develop a new model. We didn't have enough patients to do it. It wouldn't have been scientifically valid, but we did have time to try to, you know, assay our existing models and see, would any of them work on the COVID patients who we were currently caring for? And that's where this project kind of came from. So we weren't the only ones thinking about this. This was a stat news story from April 1st, the day after Michigan Medicine announced that they were looking into a field hospital, that Stanford was looking at this tool called the Epic Deterioration Index to see if it might help determine which COVID-19 patients would need ICU care, with the idea being that if you could figure out which patients don't need ICU care, those are the ones that you'd want to safely send to a field hospital. So the questions that they were trying to answer that we were also trying to answer were, you know, could this help us identify patients who need to go to the ICU so that we can intervene on those patients more quickly? And can it help us find patients who could safely go to lower acuity settings, whether that be home or, you know, a skilled nursing facility or a field hospital as an example. So shortly after that kind of that story came out, Ron Lee, who's a physician informaticist at Stanford, gave a talk as part of this human-centered AI conference that was being held at Stanford, talking about the variety of artificial intelligence-related technologies that were being deployed to try to tackle and minimize the impacts of COVID-19. And he gave this brief talk where he focused about what some of their kind of preliminary findings were with the Epic Deterioration Index. And at the time of this conference, I think they only had a handful of patients with COVID-19. So this is really just almost like case report level. Here's an example of a patient with COVID-19 that we're taking care of, and kind of what this score looks like. So then this trend line I'm showing you, that 61 is the actual score for Epic Deterioration Index. I'll talk more about kind of what that is. It's a score that goes from 0 to 100, where 0 is healthy and 100 is sick. You can see how for a given patient, it's kind of looks like it's kind of gradually going up, and mostly up, all the way from the 20s up to the 70s. Although it does have this jittery nature where it goes up and down pretty rapidly. So you could be fooled into thinking a patient got really sick and then the score comes right back down. So it's not clear if that actually was they actually were sick, or whether the score is responding to something that was overreaction. So at this point, really this is all that was kind of public in the public domain. Not much else was in the public domain for how this score performed. And so hospitals essentially had to use very limited data to figure out whether this is something they wanted to operationalize at their hospitals, and more importantly, how do they actually go about doing it. It didn't take long for an Epic press release to come out, where it starts off with, this is helping save lives. In healthcare, you often find that you get a good model, and immediately someone kind of leaps to the conclusion that use of that model has made major differences for patients. But I think the reality is probably not quite that rosy, because we don't know whether it's actually helping save lives. But I think the really impressive thing about this press release was that very last sentence that I kind of highlighted, which is that many organizations have completed validation and are already using it for these patients. And yet, despite that, there was literally nothing in the public domain about how this score actually performs for this patient population and how we should actually go about using it. So, motivated by the fact that people seem to be just anecdotally using it, at the same time that we were kind of still validating it, we wanted to actually make our work public, so that other organizations that want to validate it themselves can do it, but also as a way to benchmark or measure the effect of or the accuracy of these scores more broadly. Because this score, unlike the kind of usual risk prediction scores that we commonly use in clinical care, is not something you calculate once. It's calculated every 15 minutes. And that has major implications on how you decide to use it and how you interpret the results. And linked to that press release was this story that came out by Casey Ross in Stat News, basically saying that hospitals are using this tool before they know that it works. And that normally they would try to validate these tools, but in the absence of having, just not having enough time to do it, they're just turning it on and using it without kind of really knowing what they're getting into. And so we, took the kind of principle of first do no harm. When you use a risk prediction model to make decisions, even if you're just using it for information, you can do great harm. You can imagine a risk score where you are using to predict mortality. If you then counsel a patient's family based on that risk score, and that patient ends up choosing, a intervention or outcome that would not have been kind of compatible with what they would have done with better information, you may cause great harm to a patient if you severely overestimate or underestimate, how sick they are. And so we really felt like we needed to do better than what was out there before we could use it. And so if you read the story, actually, some of the work I'm presenting today is actually linked from this story, because we were very adamant that, we're going to be very transparent about how we're using it, about our validation work, because there's nothing else out there. So we took what I would call as a learning health systems approach to try to answer this question. And what I mean by that is this. On one hand, you've got an early warning system model or predictive model like the Epic Deterioration Index. And by itself, that model is not going to help patients get better. That model is basically going to help you re-stratify patients. And it's not until you actually do something with that information, you have some kind of a change in practice or a change in performance, that will actually result in patients, being in a better situation than they were in before. And so, in our department in learning health sciences and kind of in this general learning health systems approach, there's this idea that in order to achieve impact or better health, you need to have 3 things happen as part of your learning cycle. So first, you have to have the formation of a learning community. And we had that in the form of the command center, and we had it in the form of the COVID-19 analytics team. But next, you need to walk through this cycle. And the first cycle is that your natural practice, kind of what you're doing, has to generate data that you actually can even look at. Because if you don't measure what you're doing, you can't improve on it. Then you need to know how to interpret that data into something that you can, you would call knowledge, that you can actually act on. But even if you've got that knowledge, you've got to then actually put it into practice to act, and modify something that you're doing in order to actually improve patient care. And so this first step is kind of P to D, or performance to data. Then data to knowledge is D to K. And then K to P is knowledge to practice, or knowledge to performance. And so we had all of those pieces in place here. We had been running the Epic Deterioration Index model since 2018 in the background. So we were storing all the model predictions prospectively. So we had the data we needed to actually validate the score. We knew what the outcomes were for the COVID patients that we had taken care of for a vast majority of patients. So we had the information we needed to validate the model. And then we had a captive audience who was very attuned to what works and what doesn't work. And so we came up with some ways to modify practice based on information from the model. And then that information was actually able to get disseminated to frontline clinicians in a very timely manner, but still having a rigorous approach. So that's what I'll walk you through, is what we did and what we found kind of next. So one important thing here, which I think is something that hasn't always been true, is that we have very strong research capabilities at University of Michigan. We've got a number of groups that do work with developing predictive models. I listed my champ on here, which is one center where we do some of this work. I listed the AI lab, and another one is some of our fantastic critical care research happening in MCIRC. So that's all on the kind of, I would say, research side. Then we've got this precision health initiative across the university that's aimed to translate that research into stuff that's clinically useful and actionable, at least in the healthcare system side, although precision health is obviously a lot more broad than that. And one thing we haven't really had necessarily previously is a way to operationalize these things in our health system. And so a couple of years ago now, there was a clinical intelligence committee that was formed, and that's an operational committee whose essentially sole goal is to help safely bring predictive models to the bedside. And so without kind of any of these things, I think this would have been a lot harder to do. But because we had a deep bench of researchers to draw from, we already had stuff that was implemented, and we had access to other models that were available through Precision Health. We were able to kind of rapidly take stuff that was kind of research and bring it to the bedside, in almost like a 2-week period when this was all going on. So the Epic Deterioration Index model, what is it? It's a model that was developed by Epic Systems from 2012 to 2016. using data from multiple healthcare organizations and data from over 130,000 patient encounters. It's designed to detect patients who are going to need resuscitation, like patients who might experience a code or a rapid response, patients who are in need of ICU care, or patients who might die. With the idea being that if you could predict who's getting sicker, you could do some intervention to try to prevent them from getting sick, in some cases at least. It uses a variety of predictors. I didn't list kind of the exact labs and the exact vital signs, but the idea is that it uses kind of the most recent value and kind of whether it's abnormal or normal to come up with a 0 to 100 score about how, for how sick a patient is. So it's been adopted by over 100 Epic customers. Prior to all this, COVID-19 stuff happening, this was already widely, at least available and implemented to some degree in different ways across different health systems. We ourselves have been running it in the background since late 2018, and it runs every 15 minutes on every hospitalized patient. So the idea was we didn't turn this on to, for our COVID-19 patients. This is something we've already had running in the background for all patients that are in the hospital, but we have been still studying this score and haven't operationalized this particular score, although we have done, for other scores where so we don't have a workflow historically around this score. Coincidentally, we had just launched a dashboard of this score that we were intending to have the rapid response teams use. That was on March 4th, so very recently. That wasn't, I say coincidentally because it was done not because of COVID-19, but because that was just on our roadmap for, starting to operationalize this model, was to make it available to the kind of clinicians in the hospital who respond to patients who are getting sick, to be able to keep an eye on who are the sickest patients in the hospital at a given time. But there's a lot we didn't know. One thing we didn't know, which is kind of a data to knowledge question, is what do the numbers mean? So you get a score of like 39. What do you do with that? What does that mean? And we also didn't know, what should we do with the numbers? So let's say we knew what a 39 meant. What should be the practice changing thing we do from that? And so these are the, we really tried to answer that first question more so. And the last one, we weren't able to do in kind of a more formal way, but we at least worked closely with Vineet Chopra from Hospitalist Medicine and Robert Chang, one of our chief medical informatics officers, to come up with some reasonable next steps for frontline clinicians to take. So this model is proprietary. The documentation is only available to customers. The model predictions are available to customers, but not the coefficients. And so there's a lot we don't know about the model, even though we know kind of roughly what goes into it. And there's been a lot of concern in the literature, should we be using proprietary models when we can't actually know how they work? And a question that came up was, well, can you even validate this model? All you've got are its predictions. And so the answer is yes. As long as you know the predictions and the predictions are timestamped, and you know the outcomes and the outcomes are timestamped, there's a lot you can do to evaluate how useful that model is, even if you don't know exactly what goes into it or what functional forms it takes. You might not anticipate the different ways in which it might fail. So there are some things that you won't know, but there's a lot you can know. And that's the spirit in which we're pursuing some of this work. So what does it feel like as a clinician to use the deterioration index? So ignore the color coding for a second. This is from our preprint, and it was some of the thresholds that we kind of suggested as possibly being useful. But these first two panels on the left are people who didn't need ICU level care. And the panels on the right are patients who did need ICU level care. The blue line is needed to go to the ICU, and the red line is needed mechanical ventilation for that third panel. And I would argue that, looking at this, and this is over a 48-hour time period following admission, it feels pretty strange to use this score. If you're that person on the very left, this is someone who didn't need to go to the ICU. And yet, within a span of an hour, sometimes even minutes, the patient went from looking totally fine to looking very sick. And if you were just looking at the score at one point in time, you might be quite misled into how sick that person is. The second panel, I think we all kind of feel comfortable about, like that patient didn't need to go to the ICU, and that looks like the score makes sense. It was kind of flat and a low score. And that third panel, I think, illustrates this other thing that, that patient looks like they're really sick, several hours in, where they go into this orange zone and they score in the 70s. And then the score drops and they look like they're fine. But the next thing you know, they're in the ICU. So there's like the increase in risk almost happens after they need ICU level care, not the other way around. So, if you use the most recent score that the patients achieved to date to try to assess how good this model is, you might be misled because they might have peaked a little while ago, and their score might be very low when they get sick. And so that's a property of this index, not so much all models. An ideal model would go up when they get sick and come down when they get healthy, but it doesn't seem to be the case for this model all the time. And another thing I want to highlight was when you compare that leftmost panel and the rightmost panel, they look pretty similar, with the exception that the person on the right needed ICU level care and the person on the left didn't. The only time that person on the right enters that orange zone is after they're already in the ICU, which kind of doesn't count because we don't actually include those predictions in our thinking. So just showing you that, it's not an easy matter of just looking at this and saying, yes, this score has face validity or it doesn't. It seems to have face validity for certain cases, but not not always. And that's why we needed to do validation work. Another thing I'll just mention as an aside is that the score actually isn't available until a patient is admitted. So this kind of turquoise line or aqua line is kind of the EPIC sepsis model, which starts scoring from the moment a patient arrives in the ER. And this red line is the EPIC deterioration index model, which doesn't actually start scoring until you're admitted to the hospital. You can still physically be in the ER, but you're admitted. And so just knowing that, there's certain things we can't use this score for, like we can't use it in the ER to decide whether a patient should go to the ICU because we won't even have a score available. So we looked at all of our adult patients admitted with COVID-19 between March 9th and April 7th. We used the EPIC deterioration index calculated at 15-minute intervals to predict this composite outcome of ICU level care, mechanical ventilation, or death. Recognizing that mechanical ventilation, is something that you need to get in the ICU. So it was just a matter of which one happened first that we took, because some patients get started on the floor and then transferred to the ICU afterwards. And then we looked at a subset of patients who had been in the hospital for 48 hours and saw, if you had a low score for the first 48 hours, was there a threshold we could assign below which you were pretty much certain not to need to go to the ICU for the rest of your hospital stay? So kind of that whole, if we opened a field hospital, which patients could go there? That was kind of what we were trying to do with this additional subset of patients. And we looked at the value of both the raw EPIC deterioration index scores, as well as the slope, because one of the things Ron Lee had brought up in his talk at the Human-Centered AI Institute at Stanford was that, the slope seemed to have some value. So maybe it's the slope that matters. Are you getting sicker and sicker as opposed to the actual score itself? I'll skip over this for time, but we can come back to it. The thing I wanted to draw attention to here is that this is something that you've probably read about, but I think it really hits home when you see that 44% of our patients who are admitted to the floor with COVID-19 are African-American, which is, not the usual patient cohort that we kind of see a lot of at Michigan Medicine. So just highlighting that this is, this is not entirely because of patients being transferred from Detroit. This is, I think, there's something more to this. It may be socioeconomic, it may be something else, but this is, different cohort than I think we commonly see in a lot of our retrospective research at Michigan Medicine. We had a total of 174 patients. So I think that's worth mentioning, who were not admitted to the ICU directly, who were eligible for our analysis. So we found an error under the curve of about 0.76 when you use this model kind of, you had a kind of trajectory of the model starting from the time of admission all the way through when they have an event or they're discharged. If you look at just the slope over the last 4 hours as kind of a rolling slope, or the slope over the last 8 hours, the area under the curve is lower. So the actual score seems to have more value than the slope itself. And we didn't do any additional engineering because we didn't have another validation cohort. So you could combine these and look at something else, but we decided not to, given the small patient population that we had, relatively speaking. So we found that patients who, this is kind of a graph showing the sensitivity, specificity, positive and negative predictive value for the patients. At the very top, you can see the distribution for the maximum score that a patient reached during their hospital stay prior to having an event. So patients who exceeded a score or met a score of 64.8 even once made up almost a fifth of the cohort. And at this cutoff, the score had a positive predictive value of 80% and captured nearly 40% of cases. So it seems like for a small proportion of the population, less than a fifth of the population, that it's so it'll identify 1 out of 5 people, and it'll be 80% correct when it flags someone as being high risk. And if you look at the trajectory and see when was that threshold first exceeded, because the score bounces up and down, so you might exceed it multiple times. And you might think that, that every time you exceed it, like an alert might go out if we were to tie it to some alerting system. The average lead time was about 28 hours from when it was first exceeded to when you had the outcome for patients who did. But obviously, they might have had additional alerts in between that aren't captured as part of that. Then we looked at the patients who had been hospitalized for 48 hours who hadn't yet had an event and hadn't been discharged. And the epic deterioration index had an area under the curve of about 0.65 for those patients. So, it makes sense that the area under the curve is lower, because when you look at only those patients who are hospitalized for 48 hours, you've excluded the very high risk patients who had an event, and you've excluded the very low risk patients who were discharged in the first 48 hours. And so it makes sense that the score is not going to have, as high of AUC for that setting. And so if we were going to figure out, who could safely go to a field hospital, if you set this threshold of 37.9, which is kind of the shaded green area, the negative predictive value for the score would be 93%, and it would flag 13% of patients. So essentially, if you were being overrun with patients, this score is not good enough to give you a large number of patients that you can safely send to a field hospital. It'll capture a very small percentage of patients where it's fairly sure that they're not going to go to a field hospital. But 13% of 3,000 patients that we were expecting is still too big of a number, or fractionally too small for it to really have major value. So what do the numbers mean? In their original press release, they had a screenshot where they showed the score having a percent sign after it. The percent sign is not actually there in the operational version, but it was kind of part of their press release. So we looked at the calibration and said, if you interpret this as a percentage risk of having an outcome, does it make sense? And the answer is not really. It overpredicts risk if you consider that 0 to 100 to be a actual percentage. So it's not a percentage for sure. And I don't want to take credit for it, and correlation does not equal causation, but minutes after our press release, or probably an hour after our press release, or after our preprint came out, they actually updated their press release to get rid of the percent sign, and to show that patients don't always just go up consistently. Sometimes they actually go down. And you'll notice that they updated their color coding. As I mentioned, 37 for us would be considered low risk, and they had labeled it as kind of being a danger zone. So who knows if this was intentional or not, but they interestingly updated their screenshot to be more consistent with what our risk levels were that we kind of published in our preprint. So, our findings are in code are available. So, if you have questions about how we carried this out, or have critiques on some of the methods, please feel free to take a look and give us some feedback on this. One thing I do want to talk about very briefly is, so how did we actually operationalize the index? This all happened very quickly. We tried to be as rigorous as we could and as transparent as we could. So we did have conversations with the command center. We had a conversation with Vineet Chopra, who was, I think, medical director of the RICU that had opened to care for this patient population. And ultimately, what we did was we gave every frontline clinician who was a hospitalist one of these cards that had instructions on how to add the score to their sign out, so they could constantly see, who are their sickest patients when they're caring for patients. We operationalized a way for them to look at the trend. We added instructions for how to interpret the score. So don't look at just the most recent value, look at the maximum value that a patient has achieved to date. And some basic feedback on how to incorporate it into clinical care. So considering basically rounding on these patients first, seeing them first when you come in who have the highest scores, and prioritizing the sickest patients to spend the most time on when you're handing off from one clinician to another clinician. And there's a lot of things we did not do intentionally. So we did not set up a paging workflow where this results in an alert in real time to a clinician when a certain threshold gets exceeded. We felt like we didn't have the certainty to know that this works that well with the patients that we had to be to want to enforce a really heavy-handed workflow, which you sometimes do when you're trying to, when a model works well and you're really trying to improve a specific quality measure. You have to be a little bit heavy-handed sometimes. But in this case, this is very just informational rather than actually changing workflow at a very low level. So a lot of people to thank. The co-authors on this work, I think Jag gave me too much credit saying that I'm kind of in multiple spaces. I had a lot of collaborators on this from multiple schools, including the medical school, but also including the Michigan AI Lab in Jenna Weens' group. She runs the Machine Learning for Data-Driven Decisions, or MLD3 lab, the College of Engineering, Industrial Engineering, and IHPI. We had help from the Michigan Medicine COVID-19 analytics team, and of course, members of that analytics team, many of them are also members of the Clinical Intelligence Committee that I chair at Michigan Medicine. And so just a thank you goes out to everyone there, and many of those folks on that list are also students. So with that, I would love to hear questions, comments, and thank you for your time.
Awesome. Thank you so much, Karandeep. I'm just kind of jumping back in to let people know that I'm going to be helping moderate and everything. So either feel free to put any questions or comments you have in the chat or the Q&A, or feel free to raise your hand if you'd prefer to ask your question out loud and we can unmute you.
So let me ask a question just to get the ball rolling. So this was just absolutely fascinating, Karandeep, in terms of, especially for so many of us who are not involved with actual medical care, in terms of actually seeing how the rubber meets the road in terms of taking serious data science, doing predictions and applying them in places where it makes a difference to life and health. I assume that Epic is continuing to evolve and improve their model. Does that, and I suppose that they're doing whatever they're doing, and at some point they'll have something they'll release, and then you'll reevaluate. Is that sort of how the system works, or is there a more coordinated effort between you and Stanford and Epic and other players in this space?
Yeah, so that's a great question. So this, I think, is one of the issues with a model being proprietary, is that and it's not just the proprietary nature of it, it's that there isn't a lot of information on, model versions, for example, because you can imagine how they could periodically update it and version it, and we would know kind of when the new model is going into in effect. I'm pretty sure this is the same as the original model they developed, and it hasn't really been updated, as far as I know, from the original model. So Epic has been a good partner in that we've been able to reach out to them with questions. They've been kind of relatively open. They've internally shared their own validation work with kind of some of the groups that are using this score. But we just felt like the lack of public accountability and public knowledge on how this stuff works and how well it works, done independently, not by the Epic themselves, was an important thing. So I think to get back to your original point, one thing, we don't know that this is where we'll end up. This was a model that we had running, that was operational, that we were already scoring and saving predictions for, that we were able to, was kind of this is what we've got, let's see if this is appropriate. You could imagine we could have chosen a number of alternatives. There's like a score called the SOFA score that looks at kind of organ failure. We have a number of different scores that we run on these patients. So you could imagine almost assaying the scores one by one and seeing, is this appropriate? Is that appropriate? Is that appropriate? We just felt like this one had a lot of face value, face validity. And so it was a good place to start looking at it. But our long-term, I think, goal is to, go with what's best and what we understand and what we can communicate. And so we have an infrastructure in place at Michigan Medicine that allows us to develop our own models. And so I would say right now, this is the best that we had for this use case that was available to us. But I'm not sure long-term that this is the only solution that we would be using for this. And this may very well get replaced by models built by researchers here at Michigan Medicine. I know that Jenna Weens at College of Engineering has been doing work with Michigan Medicine, Mike Shoding, Tom Valley, Ramanji Nalamathu, myself and others to develop, a separate set of models that, and compare them against the Epic Deterioration Index for this population. I know that Chris Gillies, who I see a question from, and MCIRC they've been doing similar work to try to see if they can do better than the Epic Deterioration Index. What I think this Deterioration Index gives us is a reasonable baseline that we can then decide if we can do better than. But previously, I think we didn't have even that. And so I think this was a step forward to be able to have something, but I'm not sure this is the destination. And if we get something better that, than this Deterioration Index, after reviewing kind of what it takes to get it live, there's a chance that we would end up replacing this with something better down the line. So I see a couple of questions. I can kind of address some of them. So one question I see is from Prashant Mahajan. Hi, Prashant. About, did you get a sense of clinician gestalt about worsening, and how did that compare with the score? Yeah, so we actually had Tom Valley and Mike Shoding are two of our intensivists who were involved in this work. And so they were actually on service, I believe, in the RICU, taking care of these patients. So what they did was they actually just pulled up their patient list at one point and looked at and said, yeah, this clinically makes sense. The people with the lowest score are our healthiest patients. The people with the highest score seem to be some of our sickest patients. Another thing that we had done is we actually have a dashboard where we can look at this score in real time across the entire hospital. And what I'll say is that, if you look at top 25 sickest patients in our health system, generally speaking. And you look at how sick that 25th sickest patient is, according to the Epic Deterioration Index. When we looked at the score recently, we found that not only was the top 25 almost entirely comprised of patients with COVID-19, which itself made sense, but that we had a lot more than 25 patients who were in our historic top 25. So I think the fact that the COVID-19 patients were so sick clinically and according to the score was one thing that was helpful. And in a ward where we had COVID-19 patients, clinicians looking at it and saying, yeah, the sickest patients do look like the ones with the highest score, gave us some sense of validity. So that was, I think, but it was an important part of validation, or even the decision to look at this, because if it kind of failed that face value test, we didn't think it was going to be worth even looking at it. I see a question from Chris Gillies. Hi, Chris. On, are you doing a randomized controlled trial to validate the performance of the model? So we can, I think, talk about that more, because I think that that's something that would make sense to do. What I will say is this: the score itself, I think we were able to validate in a fair way because the score was prospectively calculated. Like, we didn't retrospectively validate it. So the score itself, I think, was prospectively scored, and so we were able to validate it in a kind of a prospective way. Whether an intervention to whether the use of this score leads to better care, I think, is maybe the question that you're asking. If we show the score versus we don't, or if we tie some intervention to the score versus we don't, that's something that we would consider doing. But the deterioration index is one that I think is the most challenging to operationalize in a really meaningful way. Meaning, if you know that someone's sick, should you send them to the ICU? Should you send rapid response out to look at them? Should you just alert the clinician? And if you do that, will you end up kind of just causing a lot of alert fatigue and harm from just time spent dealing with this? And this is not the only alert we have live. We have a sepsis alert, we have other alerts. So we have to do a lot of understanding about how the alerts intersect before we kind of tie a big intervention to this. But it would probably be linked to, so right now, no, but I would love to engage with you to get your thoughts on it. Because I do think randomized trials of this kind of stuff that have come out have been underwhelming as compared to how well you think the scores would do, partly because we don't have a good intervention to link to the scores in many cases. So I see a question from SB. Are there efforts to develop an open source scoring system similar to this? So as I mentioned, there's an effort from that Jenna Weens and Mike Shoding, Brahmaji and Tom Valley are kind of co-developing, focused on a set of models for COVID-19 called MCures. There's, I know, work that Chris Gillies is doing that he could potentially share around developing models through MCirc. And then there are a barrage of models and things available online. And there was a British Medical Journal systematic review that looked at what models are available for COVID-19. And pretty much every single model that was available, they highlighted as being low quality and at high chance of bias because of the small populations that the scores are generally being developed or validated on. Because no one hospital has the overwhelming number of patients you need to have a really robust cohort for model validation and model development. So the answer, I think, is yes, there's a lot going on, but there's a lot of people also just throwing kind of stuff at the wall and seeing what sticks. So you have to really look at what's out there and kind of weed to find the really good things. But I think it'll take a lot more collaborative effort across institutions to develop stuff that's truly kind of valid, reliable, and unlikely to be biased, while taking into account differences in demographics between places, differences in comorbidities. So it's going to take time, I think, to get to that, and that's what the science is all about.
And Karandeep, it looks like we have a question in the chat panel as well.
Oh yeah, sorry.
It's up. Yeah, you want me to read it off, or do you have it?
Yeah, so I see it. So this is a great question. You know, the EPIC. So the question is, the EPIC model gives a single score. You know, and looking at the shapes of the curves associated with data, you show that there's patterns and shapes. So beyond the scores, there are similarities in scores for the affected groups by demographics, for common graphical displays rather than just the scores. So basically, could we see how the score itself and the shapes and curves varies across different, you know, physiology and different demographic groups? So, and the correction was to see if this, beyond the scores, there are similarities in the shapes of the curves. Yeah, so you can imagine you could do some kind of, you know, trajectory-based clustering technique to look at, are there people who are generally flat, who are kind of gradually going up, and people who kind of seesaw back and forth? We felt like we just didn't have the number of degrees of freedom we needed to come up with anything valid in that respect. One thing you could think of, right, is you could think of fitting a meta model on top of the EPIC deterioration index, where we fit basically a second model that's looking at the trend and looking at a variety of things, or maybe it's even incorporating some other variables that weren't in the EPIC deterioration index, which we know are more relevant for COVID. We just felt like with the patient cohort we had, we didn't have enough patients to be able to come up with something valid that we would then be able to actually say is valid. So even if we developed it, we didn't have the number of patients to validate it. So that's why we didn't, I think, get too much into that. But there's a lot of descriptive stuff you could do. I do think that, you know, the nature of the seesaw nature of the score going up and down has not been really previously discussed when people talk about this score. A lot of it was around, you know, the slope of the score is useful. So I think we were able to show that the shape does, you know, does matter in the sense that people don't gradually get worse. They get really worse, really better, really worse, really better. And then some of those people need to go to the ICU and some don't. And so that requires a interest, you know, that requires a very unique way of operationalizing this. That's maybe different than just using the most recent value.
I don't see any more questions. I guess this is the last chance. If anybody has a last minute question. Otherwise, I guess we should thank Karandeep for a really inspiring talk, and look forward to seeing all of you for our next seminar in a week. Thank you,
Thanks, everyone.
Karandeep.